All right, hopefully we're ready to go here. Great. Well, thanks so much, Henrik, Andrea, all of the organizers, for having me make this presentation. This is going to be focused on really a couple of recent pieces of work that I've published. One exploring one topic exploring the nature of the therapy that goes on with psychedelic therapy and the commonalities with traditional psychotherapy, and another one exploring some of the lesser discussed potential pitfalls for the future of this area of medicine. So just want to show you briefly, and by way of disclosures, I do advise several companies developing psychedelics through the regulatory medical pathway. One paper that I'm going to draw from is one that I recently published with Sandeep Nayak in our group. This was in a special issue of Pharmacopsychiatry that was edited by Gerd Grunder, and this explores the psychotherapeutic aspects of psychedelic therapy, and I'll dig more into that. Another paper recently published with other colleagues that I'll draw from is this paper entitled Pharmacological Assistance for Psychotherapy. And this kind of paints a larger picture that psychedelics are actually in a class amongst with some other classes of drugs that really is a shift in paradigm of traditional psychiatric medication treatment. So, for example, other drugs that have been used in this fashion are propranolol, also the NMDA partial agonist D-cycloserine, used as an adjunct to treating phobias and some other anxiety disorders. I did a little bit of experimental work with that compound in the treatment of substance use disorders. But all of these treatments sort of differ in the sense that they are administered on a certain limited number of occasions, with the hope for lasting changes in behavior and mental state, rather than the chronic administration of substances to treat the symptoms of a disorder. So just by way of review, likely for a lot of folks in attendance, I'll just describe briefly how psychedelic therapy is different. And I am speaking specifically about psychedelic therapy, not just any therapeutic use of a psychedelic. So psychedelic therapy technically refers to this model that dates back to the late 1950s. This is the first time it was described in the scientific literature, as described by the investigators in the Saskatchewan research group, where they described the use of a high dose of a psychedelic administered after intensive preparation and rapport building with the therapist who would be present during the drug administration session. The encouragement for an introspective experience via various mechanisms such as the use of eye shades, the context of a pleasing environment, a comfortable environment, and then also follow-up discussion. So this is psychedelic therapy. It's a paradigm shift because you're only administering the substance 1, 2, 3, a limited number of times, and so far the work that we collectively have shown throughout the field is that lasting benefits are seen, whether it's in healthy normals in terms of improved quality of life, or whether it's in cancer patients dealing with substantial psychiatric distress, whether it's people with major depressive disorder, whether it's people with substance abuse disorders, such as tobacco use disorder or alcohol use disorder. And a lot of discussion is made and a lot of questions are proposed regarding the mechanisms of long-term change in psychedelic therapy. And a lot of times there's a focus, understandably, on the biological changes that mediate these long-term therapeutic effects. I think we're particularly primed to ask about the biological changes, given that psychedelics are, by definition, medications. They are biological, they are drugs, they're biological manipulations of the nervous system. However, one typically does not ask, if cognitive behavioral therapy or EMDR or prolonged exposure therapy, motivational enhancement therapy, any number of empirically validated therapies for a wide variety of mental health disorders, one doesn't typically focus on the biological mechanisms that mediate long-term change. So if one undergoes a course of therapy and they're feeling from cognitive behavioral therapy and they're feeling less depressed 6 months or a year later, one doesn't typically focus on what are the biological changes that mediated that, because it's clear that it was a psychological manipulation in the course of therapy that resulted in the change. I think an important backdrop to this to note that, I think it's a reasonable presumption that any psychological change, any behavioral change, a change in mental state always has a biological correlate. So it's never a question of whether it's biology driving the effect or psychology driving the effect. These are just different levels of analysis, and sometimes one level of analysis might be brought more fruitfully to bear on a particular question. But in the context of psychedelic therapy, I think the level of analysis that is most readily brought to bear, at least at this stage, in terms of understanding those long-term effects, are the psychological effects. Essentially, we have strong demonstrations of behavior change from a relatively discrete clinical laboratory procedure. I think by definition, what we're seeing is learning. People are changing their behaviors as a result of this experience that they go through. Again, no doubt there is going to be biological correlates of that change, but when really trying to understand why psychedelic therapy works, I think we should think much more about how psychotherapy works, than about the acute biological mechanisms. And I and others are doing work to investigate potential long-term biological correlates of those changes. Nonetheless, we need to really think about psychedelic therapy as psychotherapy. So what is psychotherapy? So as defined by Frank, it's an emotionally charged, confiding relationship with an expert who is believed to have jurisdiction over psychological healing. The psychedelic therapist steps into this role of expertise and oversight of the therapeutic context. And that's going to be true of any form of psychotherapy. It's a healing setting, so a setting that's especially set aside for this process. This is what makes it different, for example, than other helpful behaviors, such as discussions with friends and family members that are psychologically healthy. Nonetheless, there is a benefit to having a set aside occasion, a setting specifically for therapeutic healing. And psychotherapy also involves a rationale, a conceptual scheme or myth that provides a plausible explanation for the patient's suffering and means of alleviation. I think it's important to note that conceptual scheme or that therapeutic myth doesn't necessarily have to correspond to ground truth. And I'm going to touch upon this a little later. It may or may not actually correspond to ground truth, but it can be made to work in part because of the belief in that conceptual scheme. it's also, psychotherapy also involves a ritual that requires participation of both patient and therapist, that is believed to be effective. So, like the last point, it can in part be a self-fulfilling uh, prophecy. There's essentially always, just like a placebo effect is always baked in to any truly efficacious medication, the placebo effect or an expectancy effect is also baked into all of psychotherapy. A term that's been used to describe the features of psychotherapy um, that are that are that one observes across different forms of therapy that seem to contribute to its efficacy are the common factors. And research has suggested, with a few exceptions, that that these factors I'm going to list are are present and are predictive of successful treatment, regardless of the school of thought of the therapist or the nominal training that's provided in any particular treatment. So regardless if someone is a psychoanalyst or a behavioral psychologist, a cognitive psychologist, etc., it seems to be these factors are largely predictive of success. So a therapeutic alliance, that bond between therapist and the client, a cathartic and corrective emotional experience, improving mentalization. So this is referring to the ability of the client to see themselves and others in terms of the processes of thoughts and feelings. Mobilizing hope and decreasing isolation, affording a sense of being understood and valued, the development of new self-narratives, plausible explanatory scheme of ongoing problems, cognitive restructuring, enhanced expectations of self-efficacy. And I'd argue that most, if not all, of these factors that we know are strong contributors to the success of psychotherapy in general are amplified in the psychedelic therapy process. One aspect to that of that amplification may relate to this finding in the field that psychedelic therapy tends to increase the personality domain called openness to experience. This is one of the big 5 personality traits, and openness to experience refers to a tolerance to other people's points of views and an ability to hold seemingly mutually exclusive notions at the same time. So thinking more of a both and rather than an either or framework, and also an appreciation for aesthetics. In our lab in 2011, combining data from 2 previous healthy normal studies, we found that a large dose of psilocybin increased the personality domain openness to experience. And this has now been replicated in other laboratories. And so this seems to be a property of the classic psychedelics when conducted under this psychedelic therapy paradigm. So let's discuss a little bit more specifically how psychedelic therapy can enhance some of these common factors of therapeutic alliance. I've guided over 100 sessions in the course of my work, and overseen several hundred sessions of psychedelic therapy. It seems very clear to me this is a strong factor at play. One aspect of this I call it a leap of faith effect. And when you're preparing someone for a psychedelic therapy trial in informed consent, I'll have very intense conversations with people where I'll warn them about particularly the challenging experiences, what are often called bad trips. The fact that I've had people, even with, for example, combat military experience, who will say that the psychedelic session replaced combat as being the most intense, frightening experience of their life. So these incredibly strong examples to prepare someone that, yeah, you may feel like you're losing your mind. You may feel like you're dying. You may feel like you will never come back. Typically, in most traumatic situations, even though there can be dissociation, often in traumatic experience, one at least knows who they are and what is happening. Sometimes in high-dose psychedelic therapy session, even the concept of the self and this whole idea that you're a human being that normally goes through this routine, you interact with other people, you eat and you drink and you live your life and all of these things that can sometimes seem so foreign in this bizarre otherworldly experience that there's this existential dread. So when you're preparing someone for something like this, I often think, where's the example in other forms of therapy where it's that extreme? You're telling the person, I'm going to be with you during this experience, which may be the most frightening of your life. I'm going to be the one, and the co-therapist, the co-guide are going to be the ones to hold your hand and reassure you through that experience. And we're not going to leave you. And we're going to be part of that package before, during, and after. What other context in psychotherapy do you see such a strong leap of faith effect when someone says, yes, I'm willing to undergo this with you and put this complete trust in you, even when I'm in a situation where I might feel like I'm dying, where I'm losing my mind? I mean, an analogy might be, for example, in surgery, where you're giving yourself completely over to this very vulnerable state. However, you're unconscious typically during that. So even that perhaps isn't of the magnitude we're talking about here. So, as I described, some people will describe this experience as one of going to hell and back, and that just provides this extremely. It provides the context to build extremely strong rapport, even before the psychedelic is ever administered. So, just the occasion setting. By preparing someone about the magnitude of the experience, you're already setting the occasion for that strong bond that you're going to potentially go to hell and back with the person as part of a team. And then you also get beyond that, it seems pretty clear, this increased during after most sessions, this feeling that after going through the session, there's this increased bond between the guide and the client. In terms of emotional experiences, I think it's very clear. I mean, emotional lability is a hallmark of the classic psychedelics. People can have, you name it, the emotions, the sorrow, the elation, the joy, everything in between can often be at a magnitude that is far beyond what one experiences in day-to-day life. So in terms of emotional experiences, psychedelics are very strong in that angle too. Insights into problems. We've seen this. We've qualitatively interviewed people in our smoking cessation line of research about the why the psychedelic, if it worked, why the psilocybin helped them overcome smoking addiction. And often people are talking about these changes in self-identity and how smoking was tied to their self-identity and these core features of their life. So this and in other indications, psychedelics seem to have a profound effect in terms of providing these personal insights. The development of new self-narratives. I think an emerging picture is unfolding, suggesting this may be the key to psychedelic therapy. This is discussed well in Chris Letherby's forthcoming or newly published book, Psychedelic Philosophy or Philosophy of Psychedelics, suggesting that really this change in self-reference may be at the kind of the core of all of these other changes. Cognitive restructuring, it seems pretty clear that this is going on. People really can have a shift in life priorities, a shift in the way they're fundamentally thinking about things, such as their relationship to cancer and the meaning that it holds in their life. And people learn from these experiences. Self-efficacy, you see these occasions where people, I describe them as experiences, like Homer Simpson, do, sort of. I use that to describe this sense where someone says something that even when it comes out of their mouth, it sounds so obvious even to them, they feel almost stupid for saying it. So, for example, a number of the smoking cessation participants that I've worked with have said things like, I can really just decide to quit smoking. One said, it's really just like flicking off a bug. I can actually just decide to stop smoking, which sounds silly in one sense and something someone could have told themselves a million times. But it does seem like there can be this, like, such a deeply set change in self-efficacy that, it's not just sort of this cognitive notion. They sort of feel it in their heart and in their soul and in their bones, whatever analogy you want to put into it. But it's this real shift in self-efficacy, it seems. And there's a sense, a part of this, I speculate, is that unlike other forms of, certainly unlike other psychiatric medications, there's a sense with psychedelic therapy that people have done their own heavy lifting. And sometimes when people are skeptical of psychedelic therapy, and they'll sort of describe it in a way, a rather naive way of suggesting, oh, well, it's easy if you just put everyone in bliss and it's easy not to deal with your problems. I mean, which ignores the fact that we're dealing with an acute treatment. We're not talking about giving them psychedelics every day, but also ignores the fact that this is not easy. And in fact, it's extremely difficult. At the end of a high dose session, people feel emotionally and physically, psychologically completely exhausted. And you learn pretty quickly when doing this treatment that the last thing you want to mention in your discussion at the end of a session day is like the next session that they may have coming up in a week or a month. Like, the person doesn't even want to wrap their head around that. It's a very interesting example of how these drugs, while they can be abused, they're certainly not highly reinforcing or addictive substances. Usually after a high dose, the last thing someone wants to think about is using it again. They are just still reeling and exhausted from the experience. People have the sense that they really have combed the depths of their mind, that they've wrestled with the issues on their plate. I think this can lend to self-efficacy. People feel like they really have gotten to the psychological roots of their problems rather than just, having used some superficial treatment that has only treated the symptoms. So now I'll move into the pitfalls that can be encountered in psychedelic therapy. A certain set of pitfalls I'm not going to focus on here. I've written plenty about them. For example, in this 2008 paper, these are sort of more the more commonly thought of potential adverse effects from psychedelic therapy, and we have mitigating strategies to address those. The bad trip, people with predisposition for any number of disorders. I'll refer you to this paper and others to explore that. But I'm going to delve now into more subtle and maybe less obvious potential pitfalls in conducting this work. And some, but not all of these, I hope are going to be addressed if and when, and I think it's likely, psilocybin and other psychedelics are going to be approved as medical treatments. I think some of these risks are going to be addressed or at least helped by the appropriate regulations on how these are going to be used. And I made these types of proposals in this paper I published with colleagues a couple of years ago, reviewing the risks of psilocybin and how it should be regulated if it's approved as a medicine. And I recommended certain things like it's not to be given home. Like, therapists need to be trained. There needs to be this sort of strong structure, guidance over psychedelic therapy, the way that virtually all of the modern day research with high dose psychedelics is being conducted. But it's not covering all of these pitfalls. So recently I published an editorial that delved more deeply into these other, less obvious pitfalls. So I'll step you through some of these. One is a concern over the metaphysical framing. Oftentimes people in psychedelics, high-dose psychedelic sessions, they touch upon the big questions, the big frameworks, whether that's in the realm of philosophy, whether it's religious or not, whether it's considered spiritual or not by that person. And spiritual is a very messy term, means different things to many people. But oftentimes people touch upon these larger metaphysical questions. And what is the role of the therapist? I see a growing problem where therapists may get sucked into, and already are to some degree, getting sucked into really serving the role of a religious priest or a guru in terms of providing insight or guidance on these sort of larger philosophical questions that we really can't address empirically in one way or another. Is the psychedelic experience a glimpse into ultimate reality? Is it a glimpse into the mind of God? Is it, somehow increasing our perception of other dimensions that may exist that the physicists speculate about? All of this, the client or patient's best guess is just as good as anything the therapist, may guess. This is beyond our empirical and knowledge base. And I think it's critical that we be client-centered. And what I don't mean is that we tell a client, no, that wasn't a religious experience of a particular type. No, that wasn't, a glimpse of a deity. No, that wasn't plant spirits, any of that. I'm simply saying, it's critical that the client drive the bus in any metaphysical interpretations that are made, that we're there neither to confirm nor deny any of those interpretations. We're simply there to provide that fertile soil for their growth and to provide that backdrop of safety and an inclination towards psychological healing and growth, not to provide direction for these types of insights. One very salient aspect is that we see in the field is the provision of religious icons, the appearance of Buddha or Hindu gods in session rooms. It's typically more of the Eastern religions. This is a real concern. I've seen many people helped by these therapies. People that you wouldn't suspect, people that are as far away from a new age or a hippie ideology as you can imagine, political conservatives, atheists, you name it, the people, military veterans, people that one might not think of being inclined towards, psychedelics in general, they can be helped by this therapy. I think it's critical that we not paint this into a corner. People, whether they be a fundamentalist Christian, whether they be a Muslim, whether they be an atheist, they may be offended by these symbols from religions they don't associate with, and we may also not see the hidden harms where the person isn't even coming to treatment because we're already telling folks that this is not for them.
Matt, you have 3 more if you don't want questions.
Oh, okay. And I can go pretty quick. I think I'm almost done. A part of this can be just we got to watch out for the subtle suggestion of perennialism. The idea that all religions are part of one, whether that's true or not, that's anyone's personal opinion. But I see a sort of a pushing of that in psychedelic therapy. There can be epistemological harms, such as, for example, if you're pushing someone towards a belief in God, is that a good thing? Is that a bad thing? That's anyone's opinion. There can be more severe harms, for example, that can come from these treatments, such as claims of recovered memory. We do know recovered memories can be experimentally created in the laboratory. We don't know that all instances of recovered memories are false, but we know that they can potentially be false. So one of the potential harms is the accusation of, for example, a parent of sexual abuse based on a so-called recovered memory from a session. So we have to be very careful in navigating this. And there's going to be special challenges associated with the ethics and challenges of a pseudo-religious framework. We really need, in our work, whether it be survey work or laboratory work, we need to be very careful about the distinction between phenomenology, in other words, studying what people say about their experience, versus the determination of ground truth. We can study that, for example, in some work I've done with colleagues, that people have encounters with entities after they smoke DMT, that says absolutely zero about the reality of those entities, and it can be difficult for some scientists in this area from from following that distinction. And finally, clinical boundaries. It's going to be a huge challenge for psychedelic therapy. Everything we know about the importance of boundaries in clinical practice of medicine, of clinical psychology, I think there's simply a magnifying glass on the importance of those boundaries. It's hard to be associated with the most meaningful experience in someone's life, and that's not always, but often the case for a good psychedelic session. And I've been in those sessions, and so there's a real temptation to step into that role of guru and to abuse power in any number of ways, whether that be sexual, whether that be sort of just holding yourself up as sort of this kind of the person who has the knowledge about these metaphysical belief systems. One can fall into the guru complex, and one can fall into the trap of believing that somehow psychedelic therapy is so intense that it is not beholden to those old ethical rules about boundaries. And I think it's actually the opposite that's true. I think I'm going to skip this last part, just some of this critique on, we just need a lot more precision on how we use the word consciousness in this research, because it's spoken about a lot. And so, I think we have some ability to address the easy problems of consciousness, most likely with psychedelics, but we really need to watch our language and use precision. But with that, I just want to thank a large number of colleagues and funders who have made this work possible. And I'm not sure whether we have a minute or two of questions, or maybe I've gobbled up all the time.
Matt. So
yes,
thank you very much, Matt. So I think in 3 minutes I will be banned from stage because we have a full women's panel up here. So I'll be discriminated against. You are also discriminated against because we have a lot of fun here in Berlin, and it's really sad that you're not here. But I think we'll take one golden question. Yeah. So is somebody up for a golden question? Yeah, we've got somebody here.
Here's the golden question. Thank you so much for raising that question. So it's delightful to listen to you, Matt. This is Eric from Metten from the Netherlands. Good to see you.
Hi, Eric.
You're a brilliant speaker, a brilliant presenter, and it's wonderful to hear so much clinical knowledge and wisdom in your story. I don't know whether it meets the criteria that Hendrik just outlined, but how much of a therapy can you unfold on a week-to-week basis? Because are you doing this, or can somebody be doing this 5 days a week, or is there some golden rule that retrospectively you feel you need to do this 1 day a week or twice a week, or what's your rule of thumb?
For the therapy that's surrounding a psychedelic session, like the preparation and integration, is that what you're referring to, Eric?
Specifically the integration and the preparatory session, the session itself.
Oh, so specifically the session itself? Yeah, so I think these are empirical questions. Like, so far, we do have a number of examples where just a small number of sessions, and sometimes one session last in very large term benefit. I do think a risk in the field is that we, because of some sort of overly cautious approach with psychedelics, that the FDA or other regulatory bodies impose such rules, such as you can only get this 3 times in a lifetime, which I think would be a real harm. I would imagine and this is my speculation, but in actual clinical practice, for example, with
Matt, you misunderstood the question, I guess.
The role is on you as a therapist, not how many sessions you need for clinical efficacy or so. The role of a therapist, how many sessions the therapist can do on a weekly basis.
Oh, okay. Thank you, Eric. Yeah. So we struggle with that in our group. I don't have an easy answer for you. I will say that 5 sessions a week is too much. And we don't, for the various guides that we've worked with, and in my role in guiding sessions, you just can't schedule most days of the week. And so I don't know, but that is too much. Whether 1 session is the limit, or whether it's a few, we often will have 2, maybe 3 that might be getting near the boundary, but it's emotionally draining on the part of the, as you know, on the part of the guide. And so I would say not most days of the week. That is a real limit. And I think one's ability to be present with the person is going to be compromised if it's most days of the week.
Bye-bye.
Thank you. I wish I was there with you.